This is how you be the life of the party. But we're not talking about that day. Welcome to Cardio 3. All right, it's time to talk about heart attacks. It's a big topic. People in your family, you probably know someone who has had one. Talking about hypertension, talking about diabetes type 2, talking about hyperlipidemia. The seriousness of these things is their pathologic complications, and they all kind of lead to this process of atherogenesis, atherosclerosis, and eventually myocardial injury. So that's what we're going to focus on right now. So here we have basically a summary of endothelial cell injury, all of the co-contributors to cell injury, the consequences of it, such as nitric oxide and endothelin, and their effects on vasodilation, vasoconstriction, thrombogenesis, the idea of inflammation leading to white blood cells incorporating lipids, leading to those whole foam cell phenomenons, fatty streaks, and a new atherosclerotic plaque. So it really probably is not too big of a stretch of your imagination to think about when this whole process occurs in our coronary arteries, the arteries that feed our heart, their blood, that potentially bad things could happen. I think of it as kind of two dire circumstances. Circumstance number one, the plaque in the coronary artery just keeps getting bigger and bigger until it's occluding a section of my myocardium at 95%. That's a lot. That's actually a very realistic number. Or a piece of that coronary artery plaque breaks off, goes into one of my smaller coronary vessels, and completely blocks that one. In either way, you've got myocardial ischemia, which is a deprivation of blood flow and oxygen to tissue. And if that's not reversed, myocardial infarction, actual death of myocardium. I'm going to introduce you to a couple terms here, and I apologize, I'm not going to fully explain them here. Part of that is because you're going to do more work on EKGs in Med-Surg. But these terms are in such common clinical use, it's worth at least getting introduced to them now. The first terms are STEMI and non-STEMI. STEMI, ST segment elevation myocardial infarction. All this means is that the myocardial infarction, the death of the heart tissue, was so bad that it impacted the heart's ability to conduct electricity through its normal electrical channels. STEMIs are the worst of all heart attacks. They're big, a lot of myocardium is damaged. It's the worst of the worst. Non-STEMIs are still bad, but not as much of the myocardium typically is injured, such that the electrical tissue is intact enough to still conduct electricity around the heart. In clinical practice, especially if you're in a hospital, you'll hear the term USA, or unstable angina. Angina means chest pain. Let me tell you what unstable angina is by contrasting it with stable angina. I'll give you the clinical picture of a patient with stable angina. I actually had this guy as a neighbor many years back. He knew he had coronary artery disease. He would develop anginal symptoms periodically. But in the pocket of his shirt, he had a little vial. And when he developed anginal symptoms, usually when he was exerting himself, say out on the lawn, he'd pull out his little vial Open it up and take out a nitroglycerin tablet. Put the tablet under his tongue, and the angina went away. Angina that's treatable, manageable, typically with a little nitroglycerin, is stable angina. Contrast that with unstable angina, which cannot be reversed by resting and taking nitroglycerin. If you want to be more specific clinically in your documentation, you could use the term angina pectoris, which is the focus of anginal pain right below the sternum. And I say this because anginal pain can actually radiate. The classic radiation is up into the jaw and down the left arm, though the research that formulated that was mostly done in men and in women, as well as diabetics with nerve disruption. Those classic radiation symptoms may be absent. Now, those of you that work in ER and have patients coming in with crushing substernal chest pain and you're documenting angina pectoris, you'll notice that EKGs are done all the time. But technically, an EKG is just a reflection of the heart's electrical conductivity. It might suggest that a myocardial infarction is going on. It might even suggest myocardial ischemia, but it doesn't confirm it, just so you know. So the vast majority of angina, anginal pain, angina pectoris, myocardial ischemia, and subsequent infarction is either caused by, say, a thrombus that got into the coronary vasculature, or even more commonly, an atherosclerotic plaque that had been developing, say, in the left anterior descending coronary artery, and eventually grows so big that it occludes 90-95% of the LAD lumen. But plaques are kind of double-edged swords because pieces of atherosclerotic plaques can break off. So if it's in the LAD and a piece of it breaks off and then floats downstream, it can embolize into a smaller coronary vessel, cause a myocardial ischemic and potentially infarct further downstream. I'll just mention Prinzmetal's angina very quickly. Prinzmetal's angina is chest pain and myocardial ischemia caused by, underline this, coronary artery vasospasm. And what I mean by vasospasm is, here's an open coronary artery. Here's one that's undergoing a spasm. What do you think happens to blood flow distal to the site of spasm? Patients with Prinzmetal's angina may have no atherosclerotic coronary artery disease. So, how is this diagnosed? The person with Prinzmetal's comes shooting through the ER door, crushing substernal chest pain, and they're taken to what's called the cardiac catheterization lab. And a small catheter is inserted into the coronary arteries. Isn't that cool? Yeah, totally. Been doing it for decades. But guess what? No atherosclerotic plaques are found. The coronary arteries are clean as a whistle. Prinzmetal's angina is diagnosed by excluding usual causes of anginal pain. The term is diagnosis by exclusion, and it's a term that you're going to hear repeatedly. Diagnosis by exclusion simply means that the medical workup has excluded all of the other possibilities, therefore it's probably this, in this case, Prinzmetal's angina. Now, the diagnostic workup for someone with myocardial ischemia and or myocardial infarction includes all kinds of stuff. You want to know their cholesterol panel. You want to get an EKG and see what the heart's doing electrically. You want to know if there's electrolyte imbalances. A lot of them will be diabetic, so you want to know what their blood glucose is. C-reactive protein will let you know if there is an inflammatory process going on. We haven't talked about homocysteine too much, and I won't within this class. Some people who work in cardiology put a lot of faith in it as a potential indicator, an actual biologic risk factor for coronary artery disease. Some research suggests that it's not as good as others think. Therefore, right now, if the jury's out on that one, we're not going to focus on it too much. A chest x-ray will help show what's going on in the chest to make sure there's no structural things going on, such as a mass causing the pain. And one blood value that I will definitely mention, because you got to get it into your evolving clinical vocabulary, is troponins. You'll notice it talks about here creatine phosphokinase as well. And a lot of clinicians will include both of those under the umbrella term cardiac enzymes. I will tell you, they're incorrect. Creatine phosphokinase is not an enzyme specific to the heart. It's an old enzyme that people like me remember drawing and following in a serial fashion in patients that had symptoms of a heart attack. And if they had a true heart attack, as those myocardial cells were dying and lysing, CPK could be measured in the blood as those cells died and opened up and released their intracellular contents. CPK was what we used to use. However, since I started nursing to now, troponins, a more cardio-specific enzyme, have really taken over in the clinical field. The graph on the right-hand side of this slide is meant to illustrate how troponins rise and then fall as myocardium is injured, tissue infarcts, and then actual myocardial cells die, open up, and release troponin into the bloodstream. So as the injury occurs, you'll be able to measure more and more troponin over time, but then there are limits to how much myocardium died. So eventually, after the troponin spikes, it'll start to come back down again. And those of you that work in acute care and cardiology will follow these blood values to document that the ischemic event and infarct has ended and the rest of the myocardium is okay. Another test you have to get used to for this group of patients is the coronary angiogram, the cardiac angiogram, more frequently called the cardiac catheterization. The cardiac cath can be both a diagnostic and therapeutic tool, and as the name implies, a small, flexible fiber optic catheter is put into typically the femoral artery and then tunneled up through the abdominal aorta, thoracic aorta, and then into the coronary arteries, where it can literally look around. And as that catheter is looking around, so to speak, if it finds an area where an atherosclerotic plaque is occluding the vessel, that catheter is so small, a lot of times it can weave its way through the open part of the lumen, and then a balloon within the catheter can inflate. And the inflation pushes the plaque up against the vessel wall, opening up the lumen of the artery for improved blood flow. The popular name for this procedure is angioplasty. And plasty just means we're changing the shape of a vessel. It used to be that just balloon angioplasty was all that's done. In the late 90s, 2000s, a second procedure was done whereby on the end of the catheter, a small chicken wire, for lack of a better term, stent was placed. And the stent would be on the end of the catheter. The catheter would be tunneled into the coronary artery. And then when the balloon inflated, it would also open up the chicken wire stent up against the walls of the coronary artery. The reason stents were invented and used was that we were finding that balloon angioplasty wasn't enough to hold that coronary artery open long term. Stents were invented and utilized as a way to maintain vessel patency for a longer period of time. Now, what happens in the patient for whom balloon angioplasty, a cardiac cath with a stent, is not an option? Say there's 100% occlusion in the left anterior descending. You can't even get a catheter in there to do any kind of angioplasty. Or take the patient who's got, 3, 4 major blockages, and it's just not something that a cardiac cath is going to be able to do. In that setting, the next treatment option is the old school coronary artery bypass graft, or CABG, as it's known clinically. And what CABGs do, kind of similar to the intervention for peripheral arterial disease, is bypass, using a graft, the site of coronary artery blockage. The name kind of says it all. Whew! Complications from myocardial infarction. There's a lot of them. If the myocardial infarction is in a certain area around the left ventricle, papillary muscle rupture can occur and cause mitral valve disease. We're going to talk about that when we talk about valves specifically. There are many times after a myocardial infarction where enough of the heart's electrical tissue gets damaged that the heart no longer is able to contract in a coordinated fashion. That lack of contractile coordination leads to blood stasis within the heart. Remember Virchow's triad. Blood stasis is a major contributor to the development of blood clots. Clinical term for a blood clot is a thrombus. If the thrombus breaks off from wherever it's stuck to a wall, say of the, in this case, maybe the left atrium, then it becomes an embolus. After a myocardial infarction, there is an inflammatory process that occurs. You probably figured that out because there's tissue death that always elicits an inflammatory response. Sometimes that inflammatory response can be pathologic itself if the inflammation spreads to the pericardium. And there's actually a specific name for pericarditis that is secondary to a myocardial infarction. The clinical name for that is Dressler's syndrome. I point this out because people can have inflammation of the pericardium independent of having a myocardial infarction. There can be infections of the pericardium. I had a patient one time with cancer metastasis to her pericardium. Completely different reason to have pericarditis, but pericarditis after an MI equals Dressler syndrome. If enough of the myocardium is damaged, remember that myocardium, once it's damaged and dead, it does not go back to being contractile, contributing portion of the heart to cardiac output. This can put patients at risk for the development of heart failure, which we'll talk about. Now, blood clots in the heart can be a result of conduction disruption, but there can be other electrical disruptions as well, and we'll talk about those briefly. The most serious consequence of a myocardial infarction is cardiac arrest. So much of the myocardium has been injured and or died completely that the heart is no longer able to push blood out. Cardiac arrest. Cardiac arrest can also occur when enough of the heart's electrical tissue gets damaged such that it either stops stimulating the heart to beat, a condition called asystole, or another lethal electrical malfunction occurs. The two most common are ventricular tachycardia and ventricular fibrillation, both of which we'll talk about, and if left untreated, can lead to cardiac arrest.